So, welcome everybody. We're going to try and have an hour and a half focused on admission avoidance, specifically targeting people who might have autistic traits or diagnosed suspected autism. We've got some really exciting speakers joining us soon. And then the second part of the agenda might be a bit more fluid because we've got people joining from different meetings. So we've got something on digital, which would be an update from the forum that took place last week, and linked to the admission avoidance, we've got a couple of updates on volunteer schemes and peer-led review projects. I'm not sure we've got much by way of regional or national update. Initially, this date was planned to share with you the planning process for 21-22, but with everything that's happened in recent months, that has been understandably postponed. So we will get back to you as soon as we know more on planning. In the meantime, Richard, do you want to introduce your first speakers?
Yeah, absolutely. We can get straight into the agenda. So, at the beginning here, we've got some speakers from an organisation called BMIX. We work at the regional level with BMIX, who are heavily involved in the Kent system and are a patient experience organisation who have brought some speakers to speak to us today and share some of their experience of COVID and accessing care in the past. I'm going to hand over to Charlie, who's going to kind of introduce and share a bit more about BMIX as an organisation and introduce her speakers. And then she's going to kind of take us through this first 15-20 minutes of the agenda. So I'll hand over to Charlie if she's just there.
Hi, hello everybody. Can I just double check that Anna, are you here? Anna was just trying to get into the meeting. Our speakers Anna and Nigel are here. Nigel's dialing in on an audio thingy.
I see Anna on the call, yeah. Anna Livermore?
Yeah, Anna Livermore, and there should be Joanna and Nigel. I don't know if they're...
I'm here.
Are you here? Fabulous. Right. Okay. Hi. So yeah, we're from BMIX. So BMIX is we work very heavily on co-production with people with learning disabilities and autism. So we're working and learning together, whether it's to be seen working, be heard campaigning, or belong to a friendly group of people. People achieve their goals with BMIX. So we live and work in Medway, most of our work Canterbury, Dover, Thanet, Sittingbourne and Medway, but do offer some support in other areas of Kent. So we support people with learning difficulties. Some people prefer learning difficulties to learning disabilities within BMIX and or autism to speak up, so make choices, become powerful and influential. So we're supporting people to gain opportunities and become more independent within their lives. And to challenge negative attitudes on disability. That's something we work very closely together in co-production with other people with learning disabilities and autism within BMIX. We work within local communities so that people with learning disabilities are included and that they're not segregated. Or no longer segregated. So we've recently been involved in developing wellbeing and mental health support within BMIX, so like peer support and counselling, which you'll hear about from Nigel in a moment. So we've been developing and expanding the work within care and treatment reviews that we're involved in, and co-developing expert by experience input for mental health services for people with learning disabilities and autism. So we've also been campaigning for choice and person-centred care and treatment for people with learning disabilities, autism and mental health needs under Transforming Care and the Right to Home campaign. So now I'm going to hand you over to the fabulous speakers from BMIX. So firstly, we've got two speakers, and then I'm going to give you a summary of an anonymised summary of somebody else's story. So firstly, I'd like to introduce you to Anna Livermore. Anna has a form of autism called Asperger's, also known as high functioning autism. Anna works with BMIX as an expert by experience on the care education and treatment reviews, and she is also working as an EBIE on the Oliver McGowan evaluation that we're involved with, and I'm working alongside Anna with that. So Anna's going to share her experiences as an autistic woman about what it's been like to cope with during this awful COVID period and with lockdown, what the difficulties have been and what's helped us. So over to you, Anna. You're on mute.
I'm unmuted now, yeah. Otherwise I'll be talking to myself. That wouldn't be good. Yeah, so I'm Anna. I have a form of autism called Asperger's. I also have physical disabilities, and I also have mental health. I was diagnosed at 7. I'm nearly 35. I've not really received any help throughout my life. It's kind of being classed as high functioning. I don't fit into any category. I get told you're too capable, you're eloquent. Oh yeah, but we can't see your difficulties because obviously I'm very good at masking. I'm very, autism for some people is a hidden disability, so they don't see that I am, have difficulties inside. And I've always struggled to get any support, especially with mental health. So, this year has not been good because I hate sudden changes. So being told, back in whenever it was March, suddenly all your support networks, all the people that you go to regularly, your volunteering, things that you do, is not going to be on anymore. So you won't be able to see them and you're just going to have to stay at home. And I live in a tiny flat, so that was not suitable for me. So I had to go and stay with my mum. The issue was I had a complete meltdown and a complete crisis over this, was self-harming, quite unwell through the changes. My mum had gone on holiday about a day before, thinking lockdown wasn't going to come. I managed to get some support with my brother in Coventry, and the crisis team, we'll get back to you tomorrow, or we'll, have you tried this and that? And it's just, there's never that instant support when you need it. Sometimes you just want that reassurance in the moment, and a lot of these so-called helplines kind of have their own sort of stock phrase they use. Have you tried, a colouring in book? Have you tried CBT in the past? A lot of those don't work for me. Everyone with autism is an individual. Also, that was not good. I've tried to get support before COVID, and as I said, didn't fit into any support with people. I've had about 3 crises due to anxiety and sudden changes. Many of the helplines were busy, and I was told, yep, your doctor's referred you for support, so you will get that. And I thought, right. 4 months later, I thought, I have phoned them, and I was told, yep, we got your name. Apparently, no, never support. They don't know what went wrong, got no record of anything. Somebody will phone you next Wednesday for an assessment. Wednesday came, nothing happened. Oh, we're so sorry that's caused you anxiety, but, we don't work weekends. We don't offer this support anymore. Yes, everybody gets a little bit anxious because it's COVID. Well, that's everybody. Everyone's different. I have a lot of difficulties, so that makes it even harder, especially when I go about looking like everybody else, but inside it's a struggle to look normal and fit in. The only help that really helped me was BMIX were able to get funding to get a therapist, that she's going to be an official counsellor in about 2 weeks, 3 weeks time, and she has been a godsend that I have somebody that I can offload to every week that is not my mum, it's not family members or friends. I can just talk to about everything and anything. That's really helpful for me. And also I had phoned on one of them, I'd phoned 111 just to say, look, what medication can I take for my anxiety, and just for reassurance really, and they were very helpful. But I think in terms of mental health, there is just no support in that crisis moment, and they need to have more support for those that are perhaps more high functioning. I was told as a child, because I would have been better off being severely autistic, I would have got support. I think I am a person that just doesn't fit into any category or area, so that's why I slip the net a lot of the time, and it's very frustrating when I know inside how I'm feeling, but I just don't come across that, or they just don't see that, so it's very frustrating for me. I don't think it's just because I'm a woman. I think there are many people on the spectrum who also have associated mental health problems that are made worse by COVID and whatever, but they need to have a lot more support, especially for adults. It's not a childhood disability, and we all have different problems that need to be associated and looked after. You don't have to be severe to get that. So yeah, that's what I'd like to say. Is that all right?
Yeah, perfect. Thank you very much, Anna. Okay, right now I'd like to introduce Nigel Viscount and his mum Joanna. So Nigel has a learning disability and autism, and he works with BMIX. He goes to the West Track studio where he's involved with with doing music and media, and has recently been involved. He's a really passionate advocate for counselling and making counselling accessible and available for people with learning disabilities and autism, because it's not something that's generally easily provided. So Nigel has been working on a film with BMIX, which about promoting talking about your feelings and making counselling accessible, which is intended to be used as a training tool for counsellors, for training counsellors. But sadly, this has had to be halted because of a lack of funding. So, but I'm going to hand over to Nigel, who's going to share his experiences of what COVID and lockdown has been like for him and his family, and what has helped him through this time. Thank you. Over to you, Nigel.
BMX called me and Mancab called me. That helped me.
Carry on talking.
I do there.
Yeah. Carry on talking.
BMX helped me. Everything helped. Family helped me.
So how have you been feeling?
I'm feeling like loner.
Yeah.
I'm being loner and anything else more you think of?
You just say what you need to say.
I've been
Uptight, frustrated.
frustrated and everything like that. I've been my system a lot. It's not a helpful thing. And been a bit tossy. And changes don't help me either. And
You have counselling.
I have counselling, all that kind of thing. I have counselling all that. And I want to know what's happened and how I feel. So I feel.
Mm-hmm.
And that kind of thing.
So what about your film? What was your film about?
My film's about person like himself, or that kind of thing. Something like himself and nothing like that. When I could like himself, emotional, that kind of thing. I can't remember most of my films about, and I'm done.
About you?
About me, but about getting counselling, and how to handle things in the day. How to handle it and all that kind of thing. And that's what my film's about, and I'm helping people to get counselling. One of my babies, what's it called, Mum?
What?
Other one.
What?
Other one I have.
Counselling, psychiatrist?
No, another one.
Who?
What my other one had.
What?
Other one was called.
Which one?
My had Robin speaking to people.
Oh.
Communication, and that kind of thing.
So how have you been with your brothers?
Percussion.
Mm-hmm.
And percussion, that kind of thing.
And what help do you think you should have more of?
Talking.
And stop clenching your teeth.
talking, all that kind of thing. Talking, people phoning me, somewhere, that kind of thing. We can help. And that's the help I need.
You like makeup, you go out twice a week?
I got makeup, go out twice a week. B-mix, I got B-mix.
Well, you don't go to BMX. How has the virus affected you?
Oh, yeah, sorry, not good. Not very good. Wasn't helpful. Couldn't go know what to do. There's not a lot to do in the house. Probably is a lot. I don't even know it. The changes, I'm not used to it. Politicians, things like that. All that kind of thing. That's how it affects me. Explain to Mum, Bishop?
What, is that all you want to say?
Yeah, I don't know what else to say.
So is that, well then tell them.
That's what I want to say. As I say, I will say it.
Fabulous. Thank you very much, Nigel. I know from Nigel's that the counselling he finds it really helpful. He thinks everybody should have counselling, whether you've got a learning disability or autism or not. And it's when we spoke earlier, Nigel said he finds that really helpful, and making it accessible so that you've got specially trained therapists, therapists that really understand about learning disabilities and autism, and can maybe use tools like talking mats, things like that, to support people, to make sure that everybody can access that kind of therapy, sort of irrespective. And as I said, that this is an ongoing thing within BMIX, that we're looking at ways of making this better and promoting counselling for people with learning disabilities and autism. So thank you, Nigel and Joanna. So we've got quite a positive story, which is a bit weird. Positive spin, it sounds weird, but a positive spin on autism, on autism, excuse me, a positive spin on COVID. And I'm going to share Tim's story. It's not his real name because he wanted to remain anonymous, but Tim has, he's actually found the whole experience to be quite positive. He enjoyed lockdown because he sort of knew where he was at and what the rules were. And he's a gentleman who has autism, and he lives in supported living. But Tim, the reason that things have been really positive over this last few months and have worked for Tim is because he's been able to carry on seeing his family once a week. And I know this is a massive bugbear for a lot of individuals and a lot of families, and particularly people with care and support needs living in residential care or supported living. And for people such as Anna living on their own, or people like Nigel living with family who can't access people the same. But this is a massive deal for Tim, that he's actually been facilitated and enabled to safely see his family with COVID measures put in place that he can understand, to help manage those home visits safely. He's also been still going to, some of his activities have been kept open, which has enabled him to maintain some structure, predictability and routine to his week, which has been really important for Tim. And I know Anna finds that is a really important thing too. He's been able to, so he's got brilliant, his parents are really supportive. So he's got a really good support network around him, a very good team of support staff, which for those of you commissioning services is really vital about getting the right people in these jobs and paying for training people so they actually know what they're doing. Not only are they compassionate and want to be there, but that they know what they're doing, they understand about learning disabilities and autism. His staff have actually been able to, which is really vital at the moment, think outside of the box, be really creative in their thoughts about, okay, we can't do this and this, which is going to really upset him, having all of these things taken away from him, whether it's his activities, not being able to go to shops, having to wear masks, etc. So they've creatively sort of used things that are going on a day-to-day level within the home to help him work on his cooking skills, his other things that he can get involved in at home, probably domestic chores, but to hone his skills in those areas, so that he's had a full and busy timetable, which has really helped him to maintain to stop him reaching crisis or elevating into crisis state, because had he not have had all of this in place and people that understand him and can explain in a way that works for Tim about the restrictions, the reasons for the restrictions and the virus, and repeatedly, repeat this and reinforce this to him very consistently, it supported him to be able to have this experience, which, unlike the majority of the population, and particularly for people with learning disabilities and autism, has not been a positive one. So it's, getting the right support, the right time, the right people in the first place is really pivotal in preventing people having to be at risk of admission to an inpatient setting, let alone risk. So the prevention is better in the first place, sort of getting early intervention. I think that's it. Thank you.
Great, thank you, Charlie. Oh, did you want to come in there again, Nigel?
I said thank you.
Well, no, thank you. And I just want to say thank you to Anna, to Nigel and his mum Joanna, and to the gentleman who's given the feedback that Charlie just read out there, and to Charlie as well for helping kind of put this agenda together. I think you're clearly really, really important and insightful for the people on this group who are kind of commissioning and delivering care to hear these experiences and keep this really kind of front and center in everyone's mind. So thank you so much for doing that, and we'll share details for if anyone wants to get in touch with BMIX as an organisation directly after the session with the slides. So guys, thank you so much. I think I said before, welcome to stay on the call, but otherwise we'll move on through the agenda to talk about some other bits and pieces. But thank you so much.
Okay, thank you.
Bye.
Cheers, everyone. So, in terms of the agenda, I think I hope everyone enjoyed that first part and found that helpful. The next section is due to focus on the experience in Berkshire, where there's been an alternatives to admission project that Anne Nursey has been leading. I think Anne should be on the call for me to hand over to now to give that update. I'll put up the slides on the screen as well so people can see those also. Are you there, Anne?
Yeah, I'm here.
Right.
I'm here.
I'll do the slides one second.
Lovely, thank you. Yeah, hello everybody, and hello to those of you I've worked with in other areas in the past. It's nice to be in touch, and I'll just take you through these. Oh, I don't think I'll take you through those slides. I'll take you through some slides about a piece of work we've been doing in Berkshire to look at alternatives to admission. So this piece of work it was commissioned by the Transforming Care Board, and it interestingly, Berkshire's got some real geographical challenges because there are 2 CCGs which are part of different ICSs, and then there are 6 unitary local authorities. So there are an awful lot of players, and the actual numbers of people with a learning disability or autism in each of those areas is quite small. So the challenge has really been to try and think about how we can take a more collaborative and strategic approach to developing services. So the overall objective, you won't be surprised to know, is about looking at how to develop the community services that are required so that children and adults who have a learning disability or autism and behaviours that challenge can be supported well to live in their community and not to be admitted to hospital or residential placements for children unless absolutely necessary. So the Transforming Care Board decided to commission this piece of work to start kind of bottom up by asking the questions about, well, what is it we need, and by working with everybody across the system, talking to staff at the front line, staff at all levels, and talking to people with learning disabilities, people with autism and their families, to get an idea about where the gaps were, and then to try and develop some solutions. So I'm going to just show you what we've discovered, and I don't think you need to prepare yourselves for any big surprises really. I mean, a lot of this is things a lot of you have developed, and I've been to a lot of you to ask for your help in shaping some of these opportunities. Actually, could you just pop back, Richard, to the previous slide, because I'm sort of talking a bit about about some of the things on there as well. Thank you. So very broadly, we went through talking with people, workshops, webinars, task and finish groups, and learning from research and talking to other areas. But I just wanted to mention a couple of things which we've also, alongside that, tried piloting a few approaches and picking up what learning we can from just trying doing things differently. So we've done this piece of work over the course of a year, so quite slow burn, and a lot of conversations, but also an opportunity to try out some different options on our ways. So one of the things we tried was making available a pot of money that people could apply for. It was up to £10,000 per person, and the idea of it was it would respond very fast to trying to de-escalate a situation where somebody was at risk of admission, and it could be applied for from health or social care, but everybody had to be in agreement this was the right thing to do. And the idea was to try and get some creative ideas, to get people thinking more laterally, rather than just piling in more staff or looking at an admission, but really thinking laterally about, bringing in some real expert from somewhere else, or trying some more unusual therapy, or trying to talk to somebody in another area who had struggled with a similar issue, and looking at what solutions they'd found, and then trying to work with staff locally to understand it. And in some cases it was used for buying in PBS assessments and functional assessments, and sort of devising support approaches for people. We haven't continued that, but we have got some learning from it, and one of the key things was really that that quick response is really, really important, and sometimes that's really hard, especially in a complex system, and especially when budgets are very, very tight. But where it really made a difference was where people could get a very quick response, and they could do something which might have been slightly more controversial, slightly not off the shelf. So it's nothing that you couldn't do if you've got a responsive system, really functioning dynamic support system, and good personal budgets. But obviously a lot of us haven't really got to the point of having all of that as refined as we could. We've also tried out a phone line from our intensive support team, which is just a very simple solution, really. It supports the crisis team, who sometimes feel that they haven't got enough expertise to cope with the small numbers of cases that come through from people with a learning disability or autism and very challenging needs out of hours. And we've been piloting that for about just over 6 months now. It hasn't been used a great deal, but when it has, it's provided quite a lot of confidence, and it's really been quite helpful in consolidating the relationships and that sense of mutual support between different elements of the system. So we're looking at continuing that, because the cost is very low, but the impact seems to be quite significant. And the other thing we've been trying out is having a bit of capacity for supported living development. And again, that's a real challenge in our system because of the size of the local authorities, and the numbers and the very distinct individual needs that people have. It can be very difficult to commission strategically. So we tend to finish up with quite a lot of reactive purchasing. So we've made some progress by actually putting some resource into working collaboratively across the system, understanding the needs, and bidding for and getting some developments going. The kind of things all of you are doing with clustered flats and so on, but really difficult to initiate in a fragmented system. So again, we're looking at whether we can continue that kind of support. So we've now got to the stage of having 8 proposals, which we're bringing forward and to share across agencies, and we haven't got any money, but we're looking at trying to be as imaginative as we can around that, and also being realistic that we won't be able to do all of this at once. But we've put in a bid to AGE for some training around PBS. We're looking at the financial business case around reconfiguring existing provision, reducing the number of contracted beds, reducing the number of children's residential placements, and we're looking at the potential of using mental health crisis funding to focus around this group to some extent. So we kind of, the principle is that we work out what it is we need to do, and then realistically, we continue to work at that. We're on a journey of trying to work out how and when we can start to move those things forward. Do you want to take me to the next slide, Richard? Thank you. So there's rather a lot on the slide, but those are basically the 8 main proposals. Again, they're not things that are going to surprise you, but they came out as being the key things which, linking together with each other, could really make a big difference to the Berkshire system. So we've got a quite significant gap around support for children with a learning disability or autism. We don't have a learning disability CAMS service, which I know a lot of areas do. So we've got a gap which is not just around the intensive support level, but we've got a gap below that around the kind of specialist knowledge and expertise around learning disability and autism, and also around how children who've got learning disability or autism and challenging needs but don't have a diagnosable mental health need, they often bounce around the system until a crisis arises, and that's not okay. And we've been trying to design a system which plugs all of those gaps in a sensible way and fits in to the infrastructure of the existing services. So we're looking at a tiered proposal which has got really solid training and support for other services at the bottom. It's got a specialist expertise in the middle, and it's got a small element of quite intensive support at the top. So that's very much the biggest, if you like, the biggest proposal. But the other ones are important as well, and they all kind of work hand in hand. The second one is about supporting the Green Light Toolkit and Liaison to support our mental health services, and a lot of that is thinking about autism, where a lot of people are using mainstream mental health services, and mental health services often don't feel fully equipped to support them. But it's also about saying, well, when is it right that somebody with a learning disability who doesn't require that specialist learning disability knowledge and expertise has a right to use the same services that anybody else would use, and how can we support that to be the case? And we're talking about having support, so liaison support, which would start around mental health services, but then move on to emotional wellbeing services and ultimately to universal services as well. Because I was interested in what Anna and people were saying just now, in that a lot of people with autism can turn up to use a whole variety of services and find that actually staff are not skilled and confident around understanding how things might be appearing to that person, or the kind of options they might need to be able to discuss with them and how they might need to go about that. I've mentioned the supported living, so we want to create a bit of capacity to focus around collaborative work around supported living developments, and also developing the market of specialist providers.
Okay.
Sorry. PBS training, again, we've got a gap around the consistency of that. So people want more training, and they want to be able to access a similar approach across children and adults. We haven't yet got a dynamic support register, but we're starting work on that, and we're currently getting the initial stages of that work done to design a system. And what we're very focused around is that we need the register, but we also need to bring together all the other elements of support, with some clinical support, the admin for our CTR and CETR process, and to develop some really clear systems and back that up then with training and awareness raising across the system. So it's about building a really strong sense of multi-agency work, which sort of runs as a theme through all of these. We'd like to boost the challenging behaviour specialists in our community teams for people with learning disabilities. We've got one team which has had a specialist throughout, and that does seem to have, certainly anecdotally, it's really difficult to measure how much practical impact that has, because there are so many factors at play, but it does seem to have an impact, and we're keen to try and extend that out to the other teams as well. Crisis support, we're going to continue that out of hours phone line, and around support for autistic adults. I think it's a similar gap that a lot of areas are finding, is that it's a struggle to give people access to a timely diagnosis, but it's also that question of what comes after the diagnosis. And some of that is about the support for mainstream services and reasonable adjustments and skills and knowledge building. But some of it is also about having some adapted therapies and specially designed opportunities, peer support, practical support. And there's another stream of work going on in Berkshire around looking at that. So I'm not making a specific proposal around that. I'm linking across to that work and have talked to the people involved in that work to share any learning that's come out of the work that I'm doing. So very briefly on the last slide, is a summary of what we're doing next, which is we're just at the stage of trying to summarise all of this into something which doesn't overwhelm people, and then to take it's like a set of business cases really across East and West Berkshire health and social care systems to agree priorities, agree what they want to try and take forward, and to work out how we progress that and how we try and identify the funding, because though the whole case is built on, if we can manage to do these things, we'll save quite a lot of money as well as improving outcomes. You still need quite a bit of investment to get these things moving on the faith that you're going to get those savings back in the long run. And of course, not all the savings come back into the CCG or the local authority. So where we save inpatient admissions for children, those savings are in NHSE. So it's complex. We've got a bid in to AGE for PBS training. We started work on the Dynamic Support Hub with some transformation funding from NHSE, which helped us get that going. And we're trying to hang on to having a really clear sign-up. We're trying to get clear sign-up across the system about where it is we're trying to get to, what that might look like, but also being realistic that change is going to take time and be incremental. And that's a caper through what we're doing in Berkshire.
That's really helpful, Anne. Thank you so much. I think we have shared the slides that you presented as part of the pack that went out ahead of this session, but those include your email address. So I'm sure you'd be happy for people to reach out if they've got any questions or kind of thoughts in follow-up. If we were in a room together properly, we'd kind of do some questions, but it probably isn't the best forum to kind of facilitate that discussion. But I would say, if anyone's got any questions, either let us know now, put up your hand quickly, or reach out to Anne afterwards.
Yeah, thank you.
Thank you. I think the next person on the agenda is Nick Hanson-James to talk about digital. Is Nick on the call?
Yes, I'm here.
Hi, Nick. I think we've moved things around ever so slightly. So if you're able to give your update now, that would be great.
Yeah.
We'll flick to your slides.
Okay, yeah, if you leave it there. Right, this is just a quick update on the first digital working group systems-wide meeting that we held last Monday. I think some of the outputs on the next slide have got a bit conflated, so I'll try and share my I'll try and share my screen with you. There we go. Okay, so yeah, we held our first meeting last Monday, well attended, from across all the systems and providers. Presentations from the national team on the assurance framework that they're developing for maturity, for system maturity across the region. And we had a brief update on the Southeast system, which is characterised by very uneven development and very uneven maturity across the system. So some areas, such as delivering therapies remotely, we're doing very, very well, but on other areas, such as access to patient records, we're lagging behind. And finally, we had a presentation from the AHSNs on how they're going to support us in reaching the ambitious long-term plan targets that have been set out for us. So these were the major topics and outputs that were discussed during the meeting. These really speak for themselves. I don't know how much more you want to add to these. If But I think what is noticeable is already we're identifying particular areas that we will want to focus on, and where we're finding synergy across the system, as in we're all facing issues. As you'll see from this is a very broad range of issues, and this is just a small sample. So digital poverty, interoperability, data flow between primary and secondary care, and learning from COVID. When we're dealing with this broad range of topics, and of course the thing that characterises digital is it's a system for delivery, so it touches on everybody's work streams. How are we going to bring some order into this? So hang on, let me just and if I can, have I stopped sharing that slide?
Yes, you have.
Okay, thank you. Speaking into the void sometimes it feels like. So the next steps from this meeting, well, we were very pleased with the buy-in that we got from all the attendees. I'm beginning to get a good flow of comments, feedback, suggestions for how we can improve the meeting. So my contact details are on the slide pack. If you've got any thoughts, please send them through to myself or Natasha, the chair. We're starting to take away some of this feedback, some of these ideas, and think about how we can shape the meeting to be most effective for time-stretched systems as we go into this next phase. So we'll be discussing these changes in December, but I think the thinking is that from January, this group was already was scheduled to be every other month, and the appetite from the group suggests that we should be moving to a monthly meeting from the start of the new year. We want the systems to help us shape this meeting. This meeting is for the systems. This is for us to support achieving this enormous piece of work. As I say, it covers every work stream and sub-work stream, and bringing some order to it. Really the objectives are for us to lock in to the system all of the brilliant work that's been done so far, look at some of the work that's been done at pace under pressure during COVID, see what we can learn from that, because there's some very, very good lessons there, and to build on it. You know, we need to share our wins, and we need to stop duplicating work across the system. So hopefully the digital working group will allow us to bring some order to a huge topic and piece of work. And finally, hopefully by the start of next week, we should have a future platform set up and get everybody linked in to that and start sharing some of the documents and some of the thoughts that came out of the meeting. Does anyone have any questions?
I think helpful, Nick, and again, your details are in the pack, and some of the content you just discussed is in there too. So if anyone's got any questions or anything you'd like to feed into that group, then please kind of direct them in the way of Nick, and I'm sure Nick will join us after the kind of next meeting to give an update, either verbally or kind of offline, about what was discussed and what the kind of most recent findings are.
Thank you.
Thank you. In terms of next on the agenda, I'm just thinking about the kind of timings and the people that we know we're going to be on the call. Do we have Katrina Lake here, or should we move on to the agenda after that?
We've got Debbie on the phone, so if we do that section, Debbie and I can do a double act on that. Richard? Yeah,
let's go through straight to that. I'll bring the slides up for that, Olivia.
Thank you.
Thanks.
Shall I just get started with some context, Debbie?
Yes, please. Yeah.
So since the beginning of April, mid-April, we have had weekly and then fortnightly webinars directed at colleagues to coordinate and support the healthcare response to homelessness and rough sleeping. And what we've tried doing is share the learning and showcase different areas that might have had services in place to support rough sleepers and homeless people in different ways. And obviously there is an overlap with learning disability and mental health, as we know that many homeless people and rough sleepers have co-occurring conditions, sometimes with substance misuse issue as well. So if we go to the next slide, please, Richard. One of the webinars that we did on the 10th of September, I think, was a presentation from our health and justice colleagues on liaison and diversion services that they commission in police custody suites and that come from, that work with probation services and prisons. And some of these obviously contribute towards avoiding admission, but have a very significant role in signposting vulnerable people towards appropriate services. So I'm not going to go through the full presentation. It was recorded. There's a 20-30 minute webinars. We'll share the link. It's there on the slide. And we might have a further presentation as part of our transition topic in December from Liaison and Diversion Services, but I thought it was quite important to signpost to this service that is commissioned by NHS England and is available in every single police custody suite and with every single probation services and prisons, and targeting very vulnerable individuals who very often end up with the judiciary or law enforcement colleagues, and then that's where they become signposted towards appropriate services. And part of the work that we've been doing is signposting towards other existing resources, which is what Debbie is going to present, and it's an update on the volunteer schemes, which again, if properly used, might support admission avoidance.
So shall I share my screen?
It's on the screen, Debbie, now.
Is it?
Oh.
Okay. I won't share my screen then. Brilliant. Is it on the screen?
I can reshare. That's fine.
Thank you. Sorry.
Just tell me which ones are the ones you want there, Debbie. Is it
the volunteer starts from the next one, I think. Available roles. That's it. So in wave one, the volunteer responders weren't as well utilised as NHS England improvement hoped they would be. And so they're sort of going through a relaunch, if you like. So there's a number of roles. This is the NHS in partnership with the Royal Voluntary Service, and there are a number of roles there that they can offer around community response, patient transport, community response plus, which involves having an enhanced DBS check, sorry. NHS Transport volunteer, check and chat volunteer. There are a number of roles which are detailed on the website, and I'll give you the link of that later on. So if you could move to the next slide, please. So in terms of referring people for volunteer support, it can be made with by anybody with an NHS UK or Gov UK email. But also recently they've been accepting self-referrals, so it goes beyond those email addresses. So GPs, primary care staff can refer, social prescribing link workers, community pharmacists, mental health staff, local authorities, social care providers, and they can support a wide range of people, including those who are clinically vulnerable. So that's where the homeless population sort of falls into that category, because they have multiple health needs. So that's why we were hoping that our network would start to use more of this volunteer service. Next slide, please. So this is how you make a self-referral, but also how you contact the service. So there's their phone number and a link there with more information about the programme. Next slide, please. Now, one area of their work that's increasing is the safeguarding and wellbeing work. So food poverty, psychological well-being has obviously increased as a result of COVID, and some of their volunteers are being asked to operate within this field, and they're very keen to extend this type of work. So when I was on the call and talking about supporting the homeless, they were keen to get into this area of work, and they're keen also to deal with other disadvantaged groups. Next slide, please. So this is just a little slide which shows that these are some of the areas where the demand is slightly outstripped supply. Now you probably can't see this that well, but Portsmouth, Rother, Canterbury, Dartford, Medway, and I think it's Wealdon, the last one, where the demand has exceeded supply, and they're recruiting actively in wave 3 and 4 for more volunteers in those areas. But elsewhere, there should be volunteers who would be able to respond to undertake a particular task for a client. Their response rate's gone up significantly since the start, and at the moment they say 86% of all tasks that have been requested have been undertaken. I mean, some people, if you fall in the 14%, you might not be that happy with that, but they have got a dashboard where they monitor the requests now and can sort of hurry things along through. So they've improved their system, and their data collection is excellent, and all of the Excel spreadsheets on their activities are available on the Futures NHS website. And the next slide is from that. So again, you might not be able to see, but Buckinghamshire is the southeast area who's used this service most in terms of the number of unique clients who they've helped with at least one task to date. Some of the systems that recruited and set up their own volunteer services, like we heard on an earlier homeless health call about One Slough, and Oxford have said that they set up a One Oxford. They didn't use NHS volunteers very much the first time round, and they're down towards the bottom end. But a lot of those volunteer organisations, I know particularly in Southampton, have now stopped. So you can no longer get one of the Southampton football team to collect your prescription because they're back playing. So you know that there's now an opportunity, I think, to use the volunteer responders to fill some of those gaps. Thank you. Has anybody got any questions on that?
Thanks, Debbie, and thanks, Olivia, for that update. I think, like I said before, that this is not the easiest forum to kind of ask questions or kind of have that open discussion. But if people have got questions, please do drop them in the chat box or reach out to Debbie or Olivia to follow up with them. Thank you both for that. Very helpful. Do we now have Claudia, or shall we flip the agenda a little bit further on? Sorry, not Claudia, Katrina.
Katrina. I can't see her yet, Richard.
Her name on here. Katrina. She's our last speaker. So let's. Do you have kind of sight of her presentation, Olivia, or was that something that she was going to?
If you have you got her slides?
I've got her slides indeed, yeah.
Okay, and I'll have a go at some of it. It would be better if you heard it from Katrina rather than me. So, peer-led interview projects. I know a bit about this one. Katrina and the team have been working with the University of Sussex and Sussex Partnership Trust to do a focused piece of work and try to understand why people became admitted as an emergency in wave 1. Oh, here she is. She's just joined. Katrina, I just needed to get started for you to appear. I think you're on mute.
Sorry if I'm late. I thought I was joining at 5 past, so apologies, but I'm here now. Thank
Sorry. So I was just introducing the peer-led review.
Yeah, great. So shall I just kick off from there?
Yes, please.
Brilliant. Great. So yeah, so it's quite an exciting piece of work. Working with Sussex Partnership, NHS Foundation Trust, the research department, and also working with the University of Sussex, because one of the questions that we were very interested in is understanding something about the patients that were being admitted, the really significant increase that some systems were having when kind of COVID from March in relation to inpatient admissions. And we've done a couple of pieces of work. One is working with some of the trusts around the patient kind of cohort, if you like. So what clusters or what diagnoses are we seeing with patients that are being admitted, but also really wanting to understand something of the patient experience and patient perspective. So the initiative is interviewing 40 patients that have been admitted to across a couple of mental health trusts during COVID. They're peer-led interviews, because one of the things that the University of Sussex and SPFT reflected on when they tried to do the interviews in another way is actually people really do respond when it's a peer-led interview. So they've trained up peer interviewers. And one of the things that they're looking at is people's experience of being admitted, what could have made a difference in the context of COVID, but also we are interested in younger adults, and we're also interested in people with autism as well. So we understand something about the experience of some groups of patients that I think the intelligence is that they're struggling during COVID. And it's not just around the kind of mental health trust provision, but also the wider voluntary and community sector as well. I mean, I've got some other slides, Olivia. Shall I just go on to those, and then if there's any questions?
Yes, please.
Brilliant. So, thought it would also be helpful just to give a bit of a overview of some other work, which is really understanding or working towards better understanding the needs of people disproportionately impacted by COVID-19. And the reason this work is so important is myself and others have been working on forecast modelling. So the modelling which enables us to put some numbers on the estimated or forecast numbers of people who will be impacted by COVID, leading to a kind of a mental health need or a mental health diagnosis. But that work requires research which meets a particular kind of quality standard, which has meant that unfortunately, and this is across, certainly the work I've been involved in, but also any of the kind of the modelling tools that look at high quality research, it doesn't enable us to understand what's happening in terms of the COVID impact for people, for example, with autism. So this is a piece of work which I'm working on and working with Gavin Lockhart as well, and linking in with the National Surge Planning team so that we can develop a bit of a framework around how we understand the needs and how we need to respond to people that are excluded from the national modelling because, you know, we haven't got the research to include them. So if you just move on to the next slide, please. So this is just a quick summary of what the tool is aiming to do. It's very much in early development, so I'm kind of sharing something that I think will look very different, but if there is any feedback or perspectives at this stage, that would be great. We have brought a group together, a system modelling group. We had a meeting this morning where we're working on this together, amongst other things, and this is all age. So that group, and again, as I said, National Surge Planning Group. But the tool is really aiming to support our forecast modelling and system planning, bringing together qualitative and quantitative data, real-time data, so what's happening now, what we know is happening now, other sources of intelligence, clinical and service user carer inputs as well. And the overall aim of it is to support systems to respond to the needs of groups that are disproportionately impacted by COVID. So it's about both estimating the demand and also how, from a pathway service perspective, we need to be responding to that demand. And the final point on the slide is the one that I've just mentioned, which is about addressing the gaps in the forecast modelling tools due to the lack of available research for some groups. So just moving on to the next slide. I mean, these are just some of the groups that we really don't have robust research. So we've got bits in some of the modelling tools, but it's limited. So these are some of the groups, and there are others that we're interested in using this tool. But as I said, this list, there are others that aren't on the list as well. So just moving on to the next slide. Okay, so this is again our kind of initial thinking about how do we begin to forecast demand for particular groups. And it's interesting that if we look at some of the data about the needs of people with autism, like the Left Stranded report, which was, I think, between June and July of this year, there was quite a large online survey. It was really reporting some really significant concerns around the impact of COVID on people with autism compared to the general population. 9 out of 10 people with autism being worried about their mental health during lockdown. Those who were requiring support all the time, significantly more affected by lockdown. So again, some real concerns, which is why it's so important we build in something as robust as we can to look at how we best meet the needs of, for example, people with autism. So this is, just on the slide, so the forecast demand, just the grey box there is about actually we're needing to estimating numbers. I put with caution in there, and that's just to say it will be from a variety of different sources that get triangulated. It won't necessarily, because the research isn't happening, unfortunately, but we do need to start to put some numbers, and like I said, it's kind of triangulated across surveys and different sources of data. And again, the importance of demand and capacity planning, so we can look at what we are forecasting to be presenting within our services and within general population. Just moving on to the next slide. So how do we understand the needs of, for example, people with autism in the context of COVID? And again, there's just some pointers here about the sources of data and intelligence that we can triangulate from qualitative research, a bit like the research I mentioned with an inpatient, but also survey data, surveillance data, service user perspectives and stories and clinician feedback, national and local intelligence, and pre-COVID intelligence data and evidence base. And one of the initial, again, this is very much work in progress, but whether a helpful way to pull all this together is to identify some of the key themes that are emerging in a kind of a thematic analysis. For those of you that have been involved in qualitative research, it's a very nice way of presenting a range of different themes and issues that can support what we do moving forward and how we understand needs and different lives. And just moving on to the last slide. So the slide about how do we meet the needs, again, this is really around bringing together everything that we've collated and collected. So demand and capacity modelling, really thinking about, all the work that I think we're all familiar with, which is around COVID-19 altered interventions. Again, one of the things the research with the University of Sussex and Sussex Partnership Trust is doing is beginning to understand or ask the question about what could have made a difference. How would you have experienced have been different? And again, all the stuff we're aware of around pathway development and design. But this is really about responding to the COVID impact on our more vulnerable populations. So again, very much work in progress, but thought it would be helpful just to summarise where we've got to.
Thanks, Katrina. Really helpful. And again, I think there may be some questions either from the group we've got on the line today, or once these are shared kind of out with the kind of wider system as well. So your contact details are on there. I'm sure people will be able to reach out if they have any questions. So really appreciate that. And thanks, Olivia, for that kind of initial introduction. I think you did your best to introduce it in while we had Katrina on the line. So I think that brings us to the end of our kind of timetable and our agenda for today. I think it's been a kind of a wide-ranging kind of discussion that hopefully has been helpful to people on the call. And also, as we say, these slides will be shared and a recording of the session shared out with the system for people to review later and look if they weren't able to join today for this kind of hour and a quarter. So really appreciate everyone doing that. Olivia, do you want to kind of give any final thoughts and kind of close us off?
Thank you, Richard. So thank you so much for bringing really exceptional speakers at the start, because it's so powerful to hear service users' voice and the patients and carers who are using services and for whom we are trying to tailor services to best meet their needs. So thank you so much for having Nigel and Anna share their experience. And in a way, whilst we've meandered through the agenda, not quite in the way it was planned, we've started and ended on how do we put some efforts and thinking into really capturing people's voice, especially those people that wouldn't necessarily come to mainstream services or wouldn't necessarily feel comfortable in mainstream services. So thank you, Katrina, for talking us through this. And there's an offer and an ask, I guess, from people on the call to contribute and volunteer if they're interested and if they have something to bring the voice of people that we don't hear enough from as part of your work. Thanks to all our other speakers as well. As you said, we will share the slides, we will share the recordings. I know it's a busy period for people out there, but it's all part of the work that we're all doing jointly on the autism strategy and trying to tailor services to a particular group of people who might sometimes not feel quite at home within a learning disability autism service and not quite at home within a mental health service either. So thank you very much to everybody. We're finishing a bit ahead of time, so I hope you have time to grab a drink before your next call or your next meeting. Thank you.
Thanks, Olivia. Thanks, everybody. Speak to you all soon.
Thank you.
Thanks, everyone.
Bye.
Bye-bye. Bye.
Thank you.